Hey everyone, welcome to Be Divine, Be Well, where we will be discussing all things women's health. I'm Jess from Journey to Naturopathy, and I'm hoping you will leave these discussions more empowered to take control of your health, to ask the right questions, and to recognize that you are not alone. On this week's episode, we will be talking to Dr. Rachel Corradetti-Sargeant, an ND practicing at Conceive Health. This is an amazing clinic where naturopathic doctors and medical doctors work hand in hand to support their patients' fertility journeys. Today's topic will be on insulin resistance, which has been associated with decreased ovulation, conception, pregnancy, and live birth rates. Let's dive in.
So, insulin resistance, I wanted you to just explain in kind of layman's terms, like as simple as possible, the idea of insulin resistance.
So how I explain it to my patients is as such. So you have got glucose as your body's main fuel source, right? So you've got glucose floating around the blood. You've just had a nice meal. It's in good supply. And we've got to somehow get the glucose from the blood into the cell so that the cell can use it to do all the work that it has to do. So there's this little doorway that's perfectly shaped for glucose, but we need a key to unlock the door. So insulin, it's another hormone that we have in the body. Insulin is actually the key. So the key has to go and unlock the door and allow the glucose to come in. In a situation like insulin resistance, what's happening is essentially the key is not fitting into the door. It's not fitting into the lock. It's not able to open the door. We're not able to get glucose into the cell. So it kind of stays hanging out in the blood. And so then what the body does, specifically the pancreas, is it recognizes this problem to decide, well, why don't we try to turn up the volume? Let's try a bunch of different keys and see which one fits. So it starts sending more and more insulin out to the cell level. And so what we see initially in blood work is we'll see, before we even really start to see a shift with your fasting glucose level, is we'll actually start to see a shift with that insulin number, and that insulin number starts to go up because the body's trying to produce more and more insulin to fix the resistance problem.
Maybe you could touch a little bit on what could cause this within individuals.
So on some level, in some cases, there's a genetic link if there's a family history of diabetes. But, you know, as with most genetic situations, you have to have the terrain to allow the genetic expression to come about, right? That's kind of like the epigenetics conversation. Mm-hmm. So what's going on with lifestyle? Has there been a consistent issue with the macronutrient imbalance, enough so that we're overburdening the system with generally with carbohydrates, and you know, the body just stops listening, right? It's like, okay, I get it, it's too much, I'm just going to ignore you. So that's generally what we see going on as a cause, is just a macronutrient imbalance. And there's such a great connection between exercise and insulin, like proper insulin management and blood sugar control, that we will often see a problem when there's a low level of exercise too. When you are exercising, especially with weight, your body becomes much more sensitive to insulin. So we're talking about resistance, whereby the body or the cell's kind of like ignoring the insulin message. But when we're exercising, the cell actually becomes really attuned to insulin and much more sensitive to it, and essentially opens up and lets all the glucose sink in. Just to fuel repair and recovery.
And so in practice, what would be some common signs and symptoms which might trigger you into testing for insulin, or is it something you test all the time?
Honestly, in my work now, especially like fertility wise, it's basically like just entry level testing for me, right? I'm so surprised at how many people have even just like a low level of insulin resistance. In terms of things I might see that would send me down the pathway a little bit more, obviously if somebody is coming in and they've been told they have PCOS, or somebody thinks they have PCOS, for sure we're going to test it. If it's a patient who has trouble with their blood sugar management, in the sense that they get hangry or they get really hyperactive after they have certain foods, then I'm going to think a little bit more about that. If it's somebody who is struggling with their weight, in the sense that they're doing everything and they can't make a difference with their weight, what's going on, then we'll look a little bit deeper. If there's family history of diabetes, then I'll definitely assess. So those are some of the things that will send me down the pathway. But like for fertility, it's pretty much everybody's getting a check.
Other than PCOS, I guess, diabetes. Are there any other conditions that could predispose to insulin resistance that you know of?
So many people who are coming to see me have been diagnosed with PCOS,
Right. So there's already
right?
that connection.
Yeah. So
Mhm.
I've seen insulin resistance in people who don't have PCOS. I have a patient of mine right now who has an autoimmune thyroid disorder, and we did a little deeper digging, and she has insulin resistance too. And it's kind of like, what the heck's going on here? So yeah, so I've seen it in other people. It can be there if we've got lifestyle issues going on, maybe not a specific condition. I should say though, if we're starting to see issues with the hypothalamic pituitary adrenal axis, HPA axis, where the cortisol output is not modulated appropriately, we can definitely start to see impacts on how blood sugar is managed, right? Like you and I both know that that's an outcome of that. So in certain cases where I know the patient has high level of stress or trauma, that sometimes can be an indicator that there could be a little bit of a blood sugar situation happening here too. It's very easy for people who are very stressed to want the carbs. So let's be honest about what that intake is like, and let's be a little bit tighter about it, and let's maybe track it for a little bit to make sure that you're hitting a better target.
Testing for insulin resistance, what are you looking for exactly, and what are you doing for the labs?
Yeah, so we're looking at fasting insulin and fasting glucose. When we get those two values back on the test report, we put it into a calculator, which is something specifically called a HOMA-IR, or a homeostatic model of insulin resistance. After you put it into the calculator, you get a little value split out. It's essentially a ratio, and that will tell us the level of insulin resistance. So we're looking for patients to be between 0.5 and 1.4 ideally. Anything above 2, we're getting concerned about, more like severe insulin resistance going on. I see people as high as 14.
Wow. How often are you testing?
I'm checking every 4 to 6 weeks for my fertility patients.
Okay.
That's because we're really generally working towards like a goal, like they want to get started with their treatments or with their cycle or whatever it may be. I wouldn't necessarily test that frequently in like a general population.
Right.
I would probably do the initial like 4 to 6 week check, but then I would let them go for a little bit longer as long as we saw that the changes were making a difference.
So when you get the results back, and let's say they're above the normal range, is there a marker where you're like, you need to be referred to get metformin, or is it based on, we'd first start with lifestyle factors, etc., and see where that goes?
I always want to see what we can do with lifestyle first. And, most cases, my algorithm is, okay, here's the test result. This is your level of insulin resistance. Here's the macronutrient change we need to make in terms of carbohydrate intake. I usually start people at like 40%. I don't want them going much less than that initially, but we'll start there and see what kind of difference we can make. And then I'll have the conversation of inositol. A lot of my patients have PCOS, so we're talking about inositol anyway. And I want to see those people back in 4 to 6 weeks for follow-up testing. Let's see what the HOMA-IR number is now. If it's not really budging, okay, well, here's where we can have a conversation about let's think about metformin. I can't prescribe that. We're going to have to send you to your medical doctor, or, to the doctor that I work with at the clinic. A lot of people don't like taking metformin because it causes a lot of GI side effects for some people, but it's really great, and it can work extremely well and make a big change. I'll sometimes also bring up the conversation of berberine. I've had some patients who are on all three to keep things in control, like berberine, metformin, and inositol.
Wow.
Yeah.
So that's kind of a protocol that you would use maybe if they're not really responding as strongly as you would have hoped.
Yeah.
And they need a combination.
Yeah. Or, in some cases, and I wish this wasn't the case, but it is for some people, they want to be pregnant yesterday, but lifestyle change is really hard. And so we'll sometimes see a combination like that working better if they're not able to do as much dietary change as we would like them to do.
Right. So it's so individualized.
Yeah, long term, of course, we want people making the lifestyle change, because the impacts of insulin resistance aren't just fertility, right? This is like
lifetime.
Right. But if often in a fertility case, it's like, yeah, we want to be pregnant yesterday, so we have to do what we can do to get them where they want to be, and then over time work on those longer lifestyle goals.
So true. And I think that's, again, that individualistic approach of our medicine, and just making sure that we're meeting the goals of the patient in front of us and advising them as best as possible in the other areas of their life. And so if you see the HPA axis as a component to their insulin resistance, what types of treatment would you go through in patients like that?
All the adaptogens.
Yeah.
Just everything.
Yeah, adaptogen one.
Yeah, just like heavy adaptogen work. I mean, of course, again, the lifestyle piece is going to come up there. What are we doing for self-care? What are we doing for meditation, journaling, rest? What's going on there? Because, for most of those types of patients, it's not a thing.
Yeah.
But then also making it not feel like a to-do list of things that they have to do. So what can we do with lifestyle that feels good and feels like it can work for your day-to-day life? And then what can we do from an adaptogen perspective to try to modulate this in another way?
If we can go a little bit into the diet perspectives, what other guidelines would you often recommend as the baseline for anybody experiencing insulin resistance? Obviously, it's case by case, so this isn't like a treatment protocol for anybody watching.
Yeah, so I like to keep it kind of close to 40%. I don't really like to go less than that initially unless we're seeing a poor response from the patient. I mean, if we start going below that, then we're getting into like the keto conversation, which is not the conversation that we need to be having in all cases. It can work very well for people. It's also really extreme and can be really hard for some people to manage. So let's start at the 40% mark with carbohydrate. So that means obviously we're looking at closer to like 25 to 30% for protein, a lean protein, and then making up the rest with healthy fat. So then we have to talk about what a carbohydrate is because nobody knows. So that's when we get into the conversation of like a starchy carbohydrate versus a non-starchy carbohydrate. Okay, let's look at the starchy carbohydrates. What have we got? We've got our fruit, we've got our grains, we've got some of our vegetables that fall into that category. Let's try to limit those. Maybe we're only having one piece of fruit a day. Maybe we're only having one serving of grains a day. Maybe we're only having one root veggie a day, and that's kind of it, or maybe even less than that, depending on the person. And then we really need to strongly focus on the non-starchy vegetables with, the leafy greens and all that kind of stuff. So that is usually the conversation I'm having with people because I find it's carbs that stump them more than protein and healthy fat. Like they have a general sense of protein and healthy fat. However, having someone eat enough protein is a whole other conversation because holy smokes, everyone seems to really struggle with that one. Yeah.
I don't think we struggle on the carbs, but we definitely struggle with the protein.
Yeah, we do. I don't, and I think this is going to open up a whole can of worms, but it really brings up the whole like plant-based approach too, right? So it can be difficult to achieve the right amount of protein and keep the carbs in check if there isn't an animal source of protein in the diet.
Yeah, and
I will say that.
Yes, with that conversation, I think it definitely works for some people, but it requires effort. It's so easy with a plant-based diet to fall into deficiencies in your vitamins, in your minerals, in your protein.
And I'll usually ask patients, is it an ethical decision? Is it strictly for health purposes? You don't want to have meat in your life? I hear you. But it's going to be a lot more work. You're going to have to be like diligent about this every single day.
Yeah, just being able to set those realistic goals with your patient and kind of relieving that stress because there's stress from all angles when you come in with a woman who's trying to conceive and is struggling. Yeah. In terms of exercise, we talked about weightlifting seems to be most beneficial for insulin resistance. In terms of supplements, so you talked about berberine and myo-inositol. So I wanted to know if you could just touch briefly on what those do in the body and how they help insulin resistance.
If we want to keep it super general, it's insulin, they just make you more insulin sensitive, right? That's kind of the meat and potatoes of it. Otherwise, I'm going to get really heavy into the biochem and that's probably going to bore people. So they're just nice insulin sensitizers and they really just correct that imbalanced pathway.
Amazing.
That's how I'll put it. Yeah.
So with berberine specifically, it could be problematic in pregnancy.
Yeah, 100%. When my patients are getting a treatment plan from me, in my description of how to use it, for example, like in duration, I'm really clear about you are taking this until your positive pregnancy test. And then we're going to do this after that. So, I'll be very, very clear about that so patients aren't ever left to their own devices to decide how long they should use something.
Yeah. I watched your recent talk about insulin resistance on Instagram. I wanted to know if you can just go through different outcomes that insulin resistance can affect in terms of pregnancy and fertility so that people can understand how this relates and ties in.
Yeah, we're really looking at that from like, what does insulin resistance do? Like, why does it impact fertility? And essentially what it does is it impacts your ability to ovulate, because what we'll find with a higher level of insulin resistance is we'll find an androgen imbalance. So androgens being the male pattern hormones, more male pattern hormones, women have them, but we essentially see an imbalance where those androgens are a little bit too high. And so we have that impacting the rest of the hormones that are involved with ovulation. So we'll see an ovulation situation developing when we have an insulin resistance going on.
So once they get pregnant, will insulin affect the pregnancy?
If it's out of control, so if this is maybe something that the patient didn't know about, then they have a higher chance of developing gestational diabetes.
Right.
For sure. And so then higher birth weight babies. Yeah, I mean, that case is still possible if the patient has insulin resistance that we're managing. But obviously, if we know about it, then we're doing our absolute best to get the patient into really good habits so that the chance of developing gestational diabetes goes down.
The management of the patient's insulin resistance is not just for the fertility aspect. It definitely has an impact on the pregnancy and probably post-pregnancy as well. So
postpartum for sure, and then after long-term health, right? Because it's there.
Yeah.
So we have to watch it because we don't want these patients developing full-on diabetes.
I think that covers most of what I wanted to talk about. Is there anything in terms of insulin resistance that you can think of? Anything else that would be beneficial to talk about?
Two things to mention. It can correct very quickly. Like, I'm shocked, and it's probably because the population I work with, they're very willing to make change. So like I said, my typical approach is let's have you make the changes, and then 4 to 6 weeks, let's circle back and see. I've seen it cut itself in half after 4 to 6 weeks of change, which is amazing. Mm-hmm. I've also seen it go the other way where I check in with patients and I'm like, oh, what happened? And they're like, oh yeah, it's been a really rough month. Mm-hmm. So, it can quickly rebound too. So it's something you're always having to be on top of. I would say the other piece that's really important is just that outside of fertility, outside even of the women's health sphere, I really feel like insulin resistance is something that should be investigated for more people. Mm-hmm. Yeah, right? I mean, just thinking about the staggering number of diabetes cases that are out there, the number of people that have a genetic predisposition to that, why wouldn't we? It's not a difficult test to do. You fast for 12 hours, you go to the lab, there you go, and then you'll know. I really think that for a lot of people, there should be a little bit of a better investigation into that, especially when we're having conversations about Alzheimer's specifically being sort of along that vein of like a type 3 diabetes, right? Like a blood sugar imbalance. Why wouldn't we be investigating this in more people? So I think it really goes outside of fertility.
Yeah, for sure. And I think it's something that you are getting tested early enough. There you go. You got a good key to start working on it now, instead of finding out about it when you're in the diabetic stage. There's certain testing that could be done a little bit more frequently with patients before they're even having symptoms, just a basic insulin resistance test, especially because PCOS is very prominent in the population. With the basic criteria, it's so common. And so with that in itself, it just seems like it should be a basic test when you get your hormones checked with your MD during your physical test, if that happens. I definitely learned a lot today, and it was so well explained. So thank you so much.
You're welcome.
I hope you all enjoyed today's episode and learned something new. Please comment below any questions you have or topics you want to learn more about. You can follow me on Instagram at Journey to Naturopathy to keep up to date with any resources and upcoming content. Thanks for watching, and stay tuned for the next episode of Be Divine, Be Well.